Scleritis. Before we go to our topic, I request everyone to be silent and listen. If I find anybody talking, I will not allow him to remain. So mind, this is first and last part. I mean what I am saying. So first of all, we will see what is scleritis and episcleritis. Scleritis and episcleritis. This itis means what? Inflammation. It means inflammation. So episcleritis is inflammation of the episclera, and scleritis is inflammation of the sclera. So before we proceed for the pathological condition, we will review a bit the anatomy of the sclera. So sclera is the outer coat of the eye. It is the outer coat of the eye coat. It forms around 5/6 of the eye coat. How much? 5/6 of the eye coat. And it, what are its functions? Its functions are to maintain the contour of the eye coat. It protects the eye because it's a strong structure. It's a collagenous. It is collagenous. And number third, it maintains the intraocular pressure. It maintains the intraocular pressure. So these are the few functions of the sclera. Then if we go by the dimension, the scleral thickness varies. Scleral thickness varies. It is around 0.5 or 0.6 near the limbus. How much? 0.5 or 0.6 mm, not centimeter. Don't tell people centimeter. It's 0.5 to 0.6 mm. That is less than 1 mm. And near the posterior edge of this sclera, around the optic nerve is around 1 mm. How much? 1 mm. So, if we see where is the thinnest scleral thickness, anybody can tell me? One at a time. Where's central posterior? Get up. Huh? Okay, just posterior right, you are right. So, absolutely right, very good. So, it is just posterior to the insertion of the rectal muscles, but not at insertion. Just posterior to the insertion of the rectal muscles. What is the diameter of the sclera? So, if you see sclera like this structure, what is the diameter? It's around 22 mm. How much? Around 22 mm. So these are the few things about the scleral thickness. Now we talk about the maintain silence, no whispering. If I find anybody, I'll put him outside this gate. So the sclera has two layers basically, episclera and sclera. And third one is the lamina fusca. Lamina fusca. What's episclera? Episclera is a collagenous structure. It's a collagenous structure which contains glycoproteins. And it is the vascularized part. It is the vascularized. It has two complexes of the vessels, two systems of vessels. One is the superficial vessels, and other is the deep system of vessels. Then if we go down, we have the sclera proper. Which is collagenous. It contains elastin mainly. It is the almost an avascular structure. It's an avascular structure. And number third is the lamina fusca, which is the innermost layer of the sclera. And what it contains? It contains mainly collagen and it contains pigmented cells, melanocytes. It contains and melanocytes gives color to this. Why it called lamina fusca? Because it's slightly brownish. Because of the presence of melanocytes. Next. Then, if we classify the inflammation of the Sclera, as I told you, we have two things, episclera and sclera. We have episcleritis and scleritis. So episcleritis have been divided into nodular and diffuse. Diffuse and nodular. Scleritis has again been divided into anterior and posterior. So anterior you have necrotizing and non-necrotizing. Okay? Non-necrotizing is further divided into diffuse and nodular. And necrotizing is divided into with inflammation and without. So Secular, anterior and posterior. Anterior, posterior. There is no subclass. Anterior has necrotizing and non-necrotizing. Non-necrotizing is diffuse and nodular. Necrotizing is with inflammation and without. Next. Next. So, as I told, there are two systems of vessels. There are two systems of vessels. One is superficial vessels, they are radial. And one is deep, one is the deep. And deep vessels they are crisscross, they are branching vessels. Superficial, it is engorgement of the superficial vessels. It will give rise to what? It will give a red shape. It will give a red shape. If it is engorgement of the deep vessels, what will happen? It will give a sort of a violation space because it is covered by the superficial vessels. So superficial vessels are affected in episcleritis and deep vessels are affected in scleritis. So you have to understand that. How we differentiate superficial and deep vessels clinically? There is a test. That test is called what is that called? Phenylephrine test. What's called? Phenylephrine test. Phenylephrine is used in 10% concentration. In 10% concentration. What it will do? It will constrict the superficial vessel, but it will not constrict the deep vessel. Suppose if there is congestion due to superficial infection or superficial inflammation, like episcleritis, the redness will go. But if there is a deep congestion like scleritis, that redness will not go. So phenylephrine is used to differentiate between episcleritis and scleritis. So this is a very important test. This is called phenylephrine 10% is to be used for this test. Next. So episcleritis, we will now go to the episcleritis. Episcleritis by definition. Episcleritis by definition means what? Inflammation of a episclera. So episcleral inflammation is a benign condition. It is not serious. It is not serious. It's a benign condition, and it happens mostly in what? In women. There is a predilection for female sex, especially in a younger age. At a younger age, like 40, 45, like that. And it has generally in around two-thirds patients, that means around 60 to 70% of patients, is idiopathic. The cause is not known. Only in one-third of patients, it is associated with some systemic disorder. Okay? So first is benign. Second, it is more common in women. Number third, it is present at a younger age. It is present at a younger age. Number four, in two-thirds, it is idiopathic, cause is not known. And only in one-third, there is systemic association with the diseases. Okay? So these are the differentiating points of the episcleritis. And in a good proportion, it can be bilateral also. It can be bilateral. So it can be divided into nodular or diffuse that I told in the terminology. Next. So once we see a patient of episcleritis coming into our OPD, what he will complain of? He will complain of redness. Doctor, I have a redness in this eye. And the redness is slightly few mm away from the limbs. That's a few mm. So the conjunctural or the episcleral injection or the redness is the main symptom in that. And number second symptom, they tell we have some discomfort sometimes. But that discomfort is very mild. It is not a severe discomfort. What else they can tell? They can tell we have watery discharge, watering. And sometimes very rarely it can cause photophobia. But first symptom is redness. Second is discomfort. Third is watering. And rarely it causes photophobia. So photophobia is not the predominant symptom of episcleritis. It is rarely seen. So generally they will complain of some more predominantly redness and maybe some discomfort and some watering like that. So once we see what we are supposed to do, these are the features they will present in our OPD. What we will do? We will generally do their vision. We will do their vision, which will be normal. There will be no change in the visual acuity. Okay? Then we will examine. We will examine this with the torch light and by the slit lamp examination. So torch light examination is very important. I think this is one of the few conditions in ophthalmology where the torch light examination is important. And slit lamp examination is also equally important, but aside from slit lamp, torch light examination is important. So on torch light we see a congested area, we will see a congested area. There are a lot of vessels on that, and there can be a nodule also, it is nodule, episcleritic nodule. So episcleritic nodule you can move the conjecture over, or even the nodule can be slightly moved here and there, and there will be an area of congestion. So what are the causes of this episcleritis? As I told you, in 2/3 is idiopathic, in 1/3 there is systemic disease, and number 3 there is some allergy also. There is some allergic reaction also because it's an immune response. It's an immune response. So some allergy also can cause episcleritis, and even some food allergy can cause also episcleritis. So these are the association, clinical association of episcleritis. Then if we see the histopathology, if we see a histopathology, if there is histopathology, what is the histopathology? There is inflammation in the episcleritis. There is a lymphocytic infiltration in the episcleritis. Okay, what is there? Lymphocytic infiltration. So once we diagnose it that it is episcleritis, and the phenylketonuria test I told you, if on such a congested episcleritis we put 10% phenylketonuria 2-3 times, this injection will go, this redness will go. The most important thing is to reassure the patient and tell him it is nothing to panic, it will go. Because after 2-3 weeks, it generally goes. But there is one problem with this. It is recurrent. It is recurrent. It comes back also. After 2 months, 3 months, 5 months, it is recurrent. And number 7, some diseases we have seen here, it will be common, like gout. gouty arthritis or gout, those people who are having gout. Even I think in our society, hyperthyroidism or hypothyroidism is more common. So we have seen collectively episcleritis to be more common. So if we go for the treatment, what's the treatment of episcleritis? Hmm? Uh-huh. Tell who is there talking. You told something? Hmm?
Right.
आप बोलो किससे बोला? So treatment is all. If somebody says she can get up and tell, there's no problem. Even if it's wrong, doesn't matter.
She's right, Olu.
Hmm?
So she's right, I guess.
बोलो, get up, let us tell. Don't be afraid of speaking.
टॉपिकल स्टीरॉइड्स ले सकते हैं और सिस्टमिक स्टीरॉइड्स भी ले सकते हैं
हाँ?
जैसे सिस्टमिक स्टीरॉइड्स भी ले सकते हैं टॉपिकल स्टीरॉइड्स ले सकते हैं जैसे कि जो
जी जी। Focus की ओर इसमें कोई बात है? So what she told is right, but we need to understand that since it's a benign condition, steroids have complications. Steroids have complications. There's a one golden rule. There's a one golden rule. That is the episcleritis responds to the topical therapy, generally. And scleritis will respond to the systemic therapy. Or, okay. So, episcleritis generally we treat by lubricants or by non-steroidal anti-inflammatory drugs. We have used steroids also, but present day consensus is we should treat them with non-steroidal anti-inflammatory drops like ibuprofen, ketorolac. They are non-steroidal. They are safe. They don't have the complications of steroids. Okay. So we start with non-steroidal anti-inflammatory drugs, and you can do orally also non-steroidal anti-inflammatory drugs like naproxen, like ibuprofen, like ibuprofen. So even diclofenac. So you can give non-steroidal anti-inflammatory drugs, and then you can give also lubricants also. If patient does not respond to these, then you can give topical steroids. But topical steroids you have to give a short course, like 3 or 4 weeks in a tapering dose. Because and you have to monitor the intraocular pressure with steroids, topical steroids. So it's a self-limiting disease, so this is the treatment for it. Next. Then we have the scleritis. Then we have the scleritis. So scleritis is a more, in a way, serious disease than epilepsy. So scleritis again, it is real than episcleritis. Episcleritis is more common than scleritis. So scleritis is real. Then it has again a female predilection. It has again a female predilection. But its onset or it is generally it mentions generally between 50 and 60, above 50, above 60, like that. Because that episcleritis mentions around 40, 40, 45, like that. So the onset of scleritis is there. And number second important thing is scleritis is more serious condition. It's a more serious condition. So now the patient comes to our OPD and we have a patient of scleritis. What he will complain? So he will complain of the pain. He will complain of the pain. He will complain of the pain. So what type of pain? boring kind, but it's a very serious pain, severe pain. It's a very severe pain. It is such a severe pain, even the person gets aroused by it in the sleep. Okay, that severe pain. Then what happens? This pain, it can be referred. It can be referred to the cheek, to the jaw, or to the neck. So it can be referred to the neck, to the jaw, to the cheek. So one thing is there is a severe pain. What else? There is a redness. There is a redness. There is a redness. But this redness is like a dullish. It is not sort of a red redness. It is sort of a whitish hue. You understand? Because it's a deep redness. It is a deep redness. It is slightly having a whitish or blue hue. What happens next? They have one more thing that this pain they have, it is exacerbated by iodine. Why? Why is it exacerbated by iodine? Remember two things. It is a severe pain, okay, which aroused from sleep. Number second, it is increased by iodine. Why it increased by iodine? Anybody? You will have a cup of tea with me. Silence, silence, no side talk. Anybody? The reason is evident because the ractile muscles get attached to the scapula. You understand? Ractile muscles are attached on the scapula. So once the ractile muscles move, they are pulling on the scapula. So that is what pain. Simple. Because the ractile muscles have insertion on the scapula. So that's why there is pain on the scapula. So these are the clinical manifestations of scleritis. Okay. Then you have two types. You have a diffuse or a nodular pattern. You have a diffuse or a nodular pattern. What is diffuse and what is nodular? Diffuse is there is a uniform congestion. There's a uniform congestion like this. There's a uniform congestion. Okay, there's a uniform congestion. And it's a nodular, we have a raised disc. A nodule in the scapula. We have a nodule in the scapula. Next. So, this I told you, there are so many causes of episcleritis. Okay? But in two-thirds, it is benign. It is idiopathic. In one-third, there are causes. Cholesterol, vasculitis, neurological, metabolic, autoimmune, malignancy, chemical injuries, infection, pyometry, chlamydia, mycobacteria, bacteria, mumps, so many things. So these are some of the systemic conditions. These are some of the systemic conditions which can cause scleritis or episcleritis. One is this scleritis. This is rheumatoid arthritis. This is rheumatoid arthritis, which affects the joints. This happens this is due to a vaginal granulomatosis. Vaginal granulomatosis causes lung disease. It's a vasculitis. It's a vasculitis. So there is cavity in the lungs. What is this? This is a pinna getting swollen. There is a disease called polychondritis. That is a disease called polychondritis. And it affects the vessels of the pinna. Okay? The vasculitis type of thing. Next. So there is a differential diagnosis. There is a differential diagnosis of what? Episcleritis. There is a differential diagnosis of episcleritis. What is the differential diagnosis? Hmm? One of the differential diagnosis is conjunctivitis. How we differentiate it from conjunctivitis? From conjunctivitis, there is more congestion in the fornix. There is no congestion on the
Episcleritis.
whom is the whom? There is a congestion on the fornix. There is a congestion in the fornix. And number second is there is a discharge. There is a discharge. There is a discharge from the eye. Purulent or mucopurulent discharge from the eye. And in episcleritis, there is a congestion on the globe. There is a congestion on the globe. That's how we differentiate between episcleritis and conjunctivitis. Bilateral conjunctivitis. What is bilateral conjunctivitis? Anybody can tell me? What is bilateral conjunctivitis? It is an immune response. It's an immune response to mycobacteria or staph. And there is a, what happens is there occurs a white stripe of thing. White stripe in the center and limbus. Okay? And around that is condition. And in episcleritis there is condition to the top. There is a condition to the top. Vessel will go to the top of the nodule. Or there will be diffuse condition. There is no pale area in episcleritis. But in bilateral conjunctivitis, there is a central pale and around that will be the condition. That and around that will be the redness. Okay? So it responds to also steroids. Because the immune response. This is immune response. So I told you the scleritis. How you differentiate scleritis from episcleritis? I told you episcleritis has a superficial congestion. It is not having that much of pain. Scleritis has more pain. Okay? Doesn't it? Then, if we go by the phenylephrine test, the condition in episcleritis go with phenylephrine, but it will not go in scleritis. Number third, episcleritis is a benign condition, scleritis is a serious condition. Number four, episcleritis responds to non-steroidal anti-inflammatory drugs or even to the lubricants or to the topical steroids. But scleritis will respond to the systemic treatment, whether it is systemic steroid or systemic non-steroidal anti-inflammatory drugs or immunosuppressants or antimetabolites or even biological modifiers. So there are so many drugs for that. Next. So once you go for the laboratory study, then we have to do these tests in episcleritis or scleritis, like a CBC, ESR, uric acid, rheumatoid factor, VDRL, then fluorescein troponin antibody test, and nuclear antibody test, then test X-ray. Because there are so many diseases. Suppose we talk of tuberculosis, it can cause scleritis. So you need a test X-ray and this. Leprosy, it can cause scleritis. So you need a test for this. Syphilis, VDRL is for that. You understand? It can cause scleritis. The gout I told you, rheumatoid arthritis, other things, they can cause this scleritis. And all SLE, Wagner's granulomatous, so many vasculitis, polyarthritis, nodules, so many diseases. So they will show a raised antinuclear antibody test. So these tests are the basic in episcleritis or scleritis. Next. So treatment I told in case of episcleritis. Next. So scleritis, as I told you, it is divided into anterior and posterior. Anterior is around 98% and posterior is around 2%. Anterior is necrotizing and non-necrotizing, and necrotizing is inflammation and blood inflammation. Non-necrotizing is diffuse and nodular. So non-necrotizing forms 85%. How much? 5%. And 15% is necrotizing. 15% is necrotizing. Here you should remember always, necrotizing is generally found in systemic vascular disease. Okay? Systemic disease. And it can be also caused by infection. It can be also caused by infection, like bacterial infection, like, hmm, like streptococcus, any bacteria can cause, but most common is pseudomonas. Pseudomonas aeruginosa. Or it can be caused by fungus. Which fungus mostly? By aspergillosis. It can be caused by viral. Which virus? Huh? Herpes virus. Good, very good. Especially herpes zoster. Especially herpes zoster. Even it can be caused by nocardia. It can be caused by amoeba. So this is a long list of infectious scleritis. So that also infectious scleritis also causes a necrotizing type of disease. There is one more entity what's called surgical scleritis. That's called surgical scleritis. What is surgical scleritis? Suppose you do a telegin surgery. You do a telegin surgery. Skin causing. Then you do a cataract surgery. Because we are giving incision on sclera. It can cause sclera. Infective and non-infective both. Suppose you are doing a claviculectomy, it can cause sclera. Suppose you are doing retinal detachment surgery, you are using the scleral buckle, it can cause it can cause it can cause also scleritis. It can cause also scleritis. So there are so many things which can cause surgical induced and infective. So these are the two most important causes of scleritis. Aside from this classification. Next. So there is a immune response, as I told you, and there is a lymphocytic infiltration into the episclera or into the sclera. Okay? So it can be in the episclera or in the sclera. Next. And there is one more thing, these all systemic diseases, SLE, polyarteritis nodosa, so many diseases, they cause sort of vasculitis. Vasculitis, what they call? They call microangiopathy. They block the vessels, or they cause inflammation around the vessels. And there is ischemia, and that causes necrosis. That's one more mechanism. That's the vasculitis plus the inflammation. So these are the two mechanisms. So if you go by anterior non-necrotizing that's saying what I told you, there is a diffuse condition. Okay, it can be diffuse or nodular. The nodule cannot be moved here and here. So that is the pattern. Superficial is diffuse anterior non-necrotizing, and this inflammation and redness, and this is the nodule. Okay, so this is nodular. Anterior non-necrotizing signal. Next. So it was anterior non-necrotizing. So it responds generally to this. We don't need serious drugs for this. So we need just non-steroidal anti-inflammatory drugs and systemic steroids. So steroids will respond to systemic treatment. It will not respond to the topical treatment. So you can give fluoropropic or any non-steroidal anti-inflammatory drug. Then you can give a oral prednisolone. Then you can give a combined or circumventional steroid. So generally, the non-steroidal and the systemic steroids are enough for this condition. Next. So this is a bit serious. This anterior necrotizing with inflammation. Anterior necrotizing with inflammation. So this is so there is necrosis of the what? Of the sickle. Why the necrosis of the sickle? Because there is the blood supply is affected. Vasculitis, ischemia. Okay? So there is the blood vessel ischemic. Once there is ischemia to something, it will cause necrosis. That may be due to inflammatory or due to vasculitis. So once necrosis occurs, how it will look like? It will look like a yellow patch. It will look like a yellow patch. So there will be diffuse condition, and in the center of that there will be a yellow patch. So we can say once there is redness and there is a yellow patch, we can say this is an anterior necrotizing with inflammation. So suppose I am talking of without inflammation. What will happen with that? There will be no redness. There will be no redness. Okay, there will be no condition in it. But in this there is condition and there is a yellow flag. So, as I told, it's a very serious disease and there is a gradual also of pain and tenderness or redness, and pain becomes very severe and persistent, and it is difficult to sleep or it is transferred into analgesia. Important thing is, suppose there is a discleritis and scleritis. If we touch a sclera like this in scleritis, it will be very tender. Patient will not have a urine. But in scleritis, there will be no sign. So in scleritis, it is tender. It is tender to touch. Basically, there is a lot of tenderness on practice, particular. Next. So again, I told you there is two pieces. One is the vasoocclusion, and if you have granuloma, because there are so many diseases which have granuloma, mycobacterium, leprosy, or other diseases. So they can also start on the limb and they can go posteriorly. Posterior. So treatment in this is generally systemic steroids, and we can add also immunosuppressants, and or we can give an combined therapy. So treatment, I will tell you simply here. Treatment is almost three, four things here. One is that suppose it is a diffuse or nodule. You start with systemic steroids or systemic non-steroid. Okay? Systemic non-steroid. Then, if it does not respond, you will go to systemic steroid. Suppose it does not respond, what you will do? You will add anti-metabolites like azathioprine or methotrexate. Okay? Then, if it does not respond, you can add immunosuppressive drugs like cyclosporine or tacrolimus. Cyclosporine or tacrolimus. If it is very severe, then you have to add what? Biological modifiers. What are biological modifiers? Anybody? If anybody knows, get up. Sure मत करो. Just if anybody knows, tell me. If not, it's okay. You know? Huh? English is not used. They are sort of antibodies, but generally there is tumor necrosis factor. Tumor necrosis factor alpha. And these drugs are against that. As we have been using in COVID, and rituximab is one. other is inflicted mass. So these are biological modifiers. When they are given, when they are given, one is severe necrotizing type of disease, or patient does not respond in that order. Suppose it's a diffuse condition or it's a nodular, it will respond to all non-steroidal or steroid, nothing. But if it is necrotizing, then we have a problem. Okay? So these are the two clauses. You tell me one, systemic non-steroid, systemic steroid, then antimetabolites. What are antimetabolites? Methotrexate and azathioprine. Then we have cyclophosphamide. Okay, what is that? That is alkylating. Okay, then you have immunosuppressive. What are immunosuppressive? Cyclosporine and tacrolimus. Then we have biological modifiers, which are anti-TNF alpha. They include what? Rituximab or infliximab. So, in this condition, one patient is sclerosis and he has suppose rheumatoid or he has polyarteritis. You have to contact a rheumatologist. You cannot give treatment independently. One. So you have to discuss with the physician or with the rheumatologist. One. Number second is that suppose these drugs, as a therapy, nephrotoxin, they have very serious side effects. You have to be conscious of it. Suppose they call neutropenia, they call CBC, so we have to monitor it. You have to monitor, you have to CBC in them, you have to monitor the count. Suppose what is the important side effect of cyclophosphamide? Hemorrhage you should have. Okay. Suppose we are using suppose we are using cyclosporine or we are using immunosuppression. What it can cause? What infection? One is opportunistic. Suppose there is eye is infected with herpes zoster. It can reactivate. You understand? Reactivation of the herpes zoster. Suppose there is some opportunistic infection, what you told is that, right? Mycobacterial. Mycobacterial tuberculosis. India is a big country and it has lot number of cases of typical and atypical mycobacteria. So there is reactivation of that. So you have to be careful all along while you do treatment as it is reactivation occurs and you have to monitor the test. Suppose you are treating scleritis. Suppose you are treating scleritis. There some first point comes. You have to think it has got infection. Have I stopped steroids now, give anti-infective, antibiotics? Or if there is, suppose, nodule, which are biopsies, randomized, mycobacterial. You have to control whether you have to give now anti-mycobacterial drugs. You have to stop steroids, because steroids as a surveillance. Suppose there is a herpes zoster now causing scleritis by use of steroids. So herpes zoster can get activated. So now you have to do antiviral drugs. So you have to be careful about while treating this condition. So you can see different patterns of this. What is this? This is sort of a single thinning. That's a singular thinning. This is a congestive type of this diffuse congestion with some necrotizing facts. With some necrotizing facts. So it will come what? Anterior scleritis with inflammation. Then what is this? This is the sort of word. This is a necrosis here. There's a necrosis here. This is necrosis of the sclera and the urinary tissue has come like coral. You understand? So what you are seeing here in brown is chloride. So again here there is a redness, some redness, but then there is a signal thinning here. In this way, what is it? There is a thinning of signal, there is a thinning of signal with humidity. With so there is not much condition as compared to this. So this is called anterior necrotizing without inflammation. What is called this? Anterior necrotizing without inflammation. The other name for this is scleromalacia. What is scleromalacia perforans? Scleromalacia perforans. It happens generally in rheumatoid arthritis. It happens in rheumatoid arthritis, and the chief cause they think, though exact cause is not known, they think it is the ischemia. It is the ischemia. How do we differentiate it from this? Because here there is a huge condition. There is no condition. Here there is pain. There is no pain. Here there is some patches of labels. Here just there is thinning of signal with some blood vessels here. You understand? So there is nothing we can do. Suppose there is this type of condition. How many pages? No treatment is required. What you will do? Because there is no necrosis here, nothing signalized atrophic, totally atrophic. It has been just as it was not there. There is one treatment only, that is the signal pad cap. So you take a pad cap which is sterilized from other donor, then you will go to this. Okay? So here there is also an anti-filtration in the body. Okay? And we call it, suppose, staphylococcus. And there is an annular scleritis. You understand? Around the cornea there is thinning of the cornea. And the cornea has also ruptured. Okay? So there is one more thing that you should remember. Episcleritis, there is no effect on vision. But scleritis, there is effect on vision. Episcleritis, it does not cause uveitis, neither eyelids, nor satellites, nor colitis. But scleritis can cause. Okay? And it can affect the vision also. It can affect the vision also. So, this condition you can remember, this is acute necrotizing, inflammatory, and this is acute necrotizing, non-inflammatory. Okay? So, in this drugs I told you, starting from oral starting with oral NSAIDs, then oral steroid, then immunosuppressants, then antimetabolites, then biological modifiers. And in this, only the signal fact. Then, what is the code? Don't say it like that. Be silent. I will leave you at this. No problem. It will just take me 5 minutes. So this is a diffuse condition here. This is a diffuse condition. There is a region here which manifests here is biopsy by the lymphocytic infiltrate. And again there is a condition here on the signal. Next.
Just let's last.
So we have posterior scleritis. We have posterior scleritis. What is posterior scleritis? Posterior scleritis is where it starts from. Once we go behind the insertion of the rectal muscles, it's called posterior scleritis. It's called posterior scleritis. So there is an inflammation of the scleritis. So what will happen here? So generally it occurs in younger patients, and it's mostly caused because there is anterior scleritis is normal. You cannot find anything in the anterior scleritis. It causes proptosis. It causes proptosis. Once it causes proptosis, what will happen? There will be pain. There will be pain. I will be bulging forward. And once you see the fundus, there will be so many things. Next. And it can have a lid edema. So suppose this is the lid edema edema here, there is a proptosis here. When we see the front, this will be raised, elevated. There will be a retinal detachment because once scleritis, there is a fluid in the choroid and retina will get physically detached by the fluid. Once scleritis resolves, it gets reactive. What are the causes of agitated retinal detachment? Anybody can tell me what are the causes of agitated? One is scleritis. Choroiditis. What? Choroiditis. Anything more? Malignant hypertension. Eclampsia. Eclampsia. That was agitated retinal detachment. So, scleritis also causes retinal detachment. It can cause choroidal detachment because choroid will also leak with inflammation. So, choroid will get detached. Then it has a folds in the choroid, like these horizontal folds. These are called choroidal folds. Yeah? Choroidal folds. Then we have subretinal agitation. If you see below the macula, there is fluid. What is to be detected by OCT. That is detected by the OCT, optical coherence tomography. Next. So some investigations we have seen. Suppose chest X-ray for ED survivorship. For sacral joint, what we do? X-ray pelvis. Okay. Then B scan for posterior scleritis. What will B scan show? That is show a T sign. That is show a T sign. What is T sign? I will explain. Next. T sign means a fluid in the subcutaneous space. Fluid in the, suppose this is black here. Normally it should not be here. And there is a hypoechoic opinion. So it becomes a T sign. Once there is fluid in the subcutaneous space with a hypoechoic opinion, it means posterior scleritis. It means posterior scleritis. And one more thing is the scleral thickness increases in posterior scleritis because there is a scleral swelling. What is the normal thickness of sclera? That's 1 mm. That is, suppose it's 2 mm or 2.5 mm. That means there is scleral thickness on B scan ultrasonography. Next, suppose this is what? This is the axial view of CT scan. So it is showing very thick sclera on the left side. On the right side, it's a normal sclera. So this goes with the diagnosis of posterior scleritis. So B scan ultrasonography and CT scan. These are the two modalities of treatment or modalities of investigation for scleritis. So there is a lot of tests. We know ANCA you have heard? ANCA and ANL. ANCA is done from what? All these systemic SLE, vector, planometer, rest lifestyle. This is what is ANCA? Anti-nuclear cytoplasmic antibody. There is some C ANCA, P ANCA that you can read. They become positive systemic disease. Then CBC I know ANA is levels. Okay? Angiotensin converting enzyme level. They are raised in sarcoidosis. Then so many things like chest X-ray, C-reactive protein, ESR, fluorescence, actually B27 levels. Important. Okay? Like seronegative spondyloarthritis. Then Montos test for tuberculosis, VDRL for syphilis. Only one thing has not diagnosed. That has to be clinical. What is that? Herpes zoster. How you can diagnose herpes zoster? You have to be a clinical diagnosis. You cannot take biopsy and you can detect. Next. Next. It's a clinical way. So these drugs I told you. Corticosteroids, cyclophosphamide, azithromycin, cyclosporine, methylphenidate or mycophenolate. Mycophenolate is staying in the glass, methylphenidate or methylphenidate. Okay? Cyclooxygenase is the non-steroidal anti-inflammatory. Okay, now next. These are the last one or two slides. What are the scleritis complications in that? What it can cause more? So there can be a keratopathy. There can be a keratopathy. Keratopathy means that these ulcers, once they reach the limbus, they can cause most important peripheral ulcerative keratitis. PUC. What's called PUC? Peripheral ulcerative keratitis. So the cornea, there is an ulceration in the peripheral cornea. And one more is that called sclerosing keratitis or sclerokeratitis. That means the inflammation from the sclera is going into the stroma of the cornea. And once it goes into the stroma, it causes hydrosis. It causes hydrosis. Then you have uveitis that I told you, scleritis is associated with uveitis. Then I told you glaucoma. Why should be there glaucoma? Hmm? Increase? One minute. You get it? Increase? Huh?
Why?
Due to what? Cause?
Steroid.
Inflammation. Yes, one of the causes is inflammation. What type of inflammation? Uveitis. Uveitis can cause glaucoma because uveitis stages can block the traffic inflammation. One. Other steroids we are using. We are using high dose steroids. They have a side effect glaucoma. Number third, there is a effusion syndrome. There is a effusion syndrome. Chloride is getting detached. The ciliary body is getting detached. That can cause an angle closure glaucoma. That can cause an angle closure glaucoma. So these are the three mechanisms of glaucoma. One is steroid, other is inflammation or uveitis, and third is the ciliary body effusion or choroidal effusion, which can cause an angle closure glaucoma. Then we have the cataract. What's the cause of cataract? Again, inflammation can cause cataract. Steroids can cause cataract. So there is an increased incidence in them. Then fundamental movement is I told you all these things in what? In posterior scleritis. The choroidal bone, the subretinal bone, the discal bone, the retinal bone, the choroidal detachment or retinal detachment, exudative. So this means exudative retinal detachment. Next. So treatment I told you the scleral pad in what? Necrotizing without inflammation. Necrotizing without inflammation. Or it is a corneal breach, it is a corneal perforation that can be sealed by what? Corneal tissue. That can be sealed by the corneal tissue. If suppose there is a rupture in the cornea, clearly, we have to use a fluid or a corneal tissue. Next. Thank you.